Hello, and welcome to Back to the Science. I'm Dr. Susan Oliver, and I'm a scientist, and this is Cindy Oliver, and she's a dog. Now, before he went totally troppo with his bonkers clock videos, Dr. John Campbell made a video with Dr. Peter McCullough and Mr. Nicholas Holscher about a myocarditis paper that they have recently published. Because I'm a glutton for punishment, I decided to listen to it while I was doing a weight workout. And I must say that I was shocked because McCullough continually quoted statistics that were patently false and misrepresented a number of papers. But Campbell just sat there and accepted everything without question. So, this is the actual myocarditis paper here, and it purports to be a review of 28 cases of people who died from myocarditis following COVID vaccination. Although, interestingly, two of the cases look suspiciously like they are the same person, as one of the studies reference states it covers all 8 deaths from Korea, and another study reference covers a death from Korea. That just happens to be the same sex, age, vaccine, and dose number as one of the cases included in the other 8. But hey, maybe it's just some huge coincidence. But that's by the by. I'm not really going to critique the paper because I'm not qualified to do so. But it has been critiqued by at least 2 people who are qualified. And those people are Dr. Frank Han MD, who is a UIC adult congenital and paediatric cardiologist, and Dr. Jonathan Laxton MD, who is an internal medicine physician and assistant professor of medicine. And I'll provide a link to their critique in the video's description. But let's get back to the video and the various bollocks claims made by McCullough and aided and abetted by Campbell.
But prior to the pandemic, myocarditis occurred at a rate of, somewhere around 4 cases per million per year. So in the United States, that means maybe about 1,200 cases in the entire country per year.
Yes, 4 per million people per year does sound quite rare. Only thing is, the number is total bollocks. So here McCullough is actually misquoting one of his own papers. This is a paper here, and it's basically just a dodgy VAERS dumpster dive. If you are interested in knowing more, I will provide some links to critiques in the video's description. So this is a paragraph where the claim is mentioned. And as you can see, it actually says 4 per million children every year were affected by myocarditis before the pandemic, not 4 per million people. But guess what? Even that number is bollocks. This is the paper that is referenced for the quote. And as you can see, it says the overall incidence in children under 15 years is 1.95 per 100,000 person years, which translates to 19.5 per million children every year, not 4. And these are just hospitalised cases. And even that doesn't tell the whole story because cases are markedly higher in children aged over 13 years and in males in particular. In fact, in males aged 15 years, the incidence is 181 per million children every year. And remember, this is prior to the pandemic. So that's children. What about in the population overall? Well, that's what they looked at in this study here. In fact, they looked at changes overall in myocarditis between 1990 and 2019, which of course were both before the pandemic. So these are the results here, and the top row is the results globally. So in 1990, the age standardised incident rate was 16.74 per 100,000, or 167.4 per million people per year. And in 2019, it was 160 per million people per year. So just a bit more than the 4 per million people per year claimed by McCullough. In fact, 40 times more. And again, the incidence was higher in males than females, climbing to about 200 per million per year in males.
Prior to the pandemic, I had only seen 2 in my entire practice. One sadly passed away.
So McCullough is admitting that he doesn't have a lot of expertise in myocarditis. Fair enough. Of course, he still has much more expertise than me, which is why I'm sticking to false statistics and misrepresentation of studies in this video. I'm going to leave the debunking of the more technical stuff to those who do have expertise, and there are quite a few.
What was it motivated you to write this paper looking specifically at COVID-19 vaccines? Because surely we've had a pandemic. Isn't that going to account for these cases of myocarditis, the viral infection itself?
You know, there was a great concern. Ralph Barrick published, actually in the journal that I was the senior associate editor of for many years, American Journal of Cardiology. He published back in the 1990s that human beta coronaviruses could actually cause myocarditis in animal models if actually the animals were exposed to enough of it. He literally flooded the animals with beta coronavirus could cause some myocarditis. So during 2020, there was an incredible search for myocarditis. There were studies in the U.S. military, the Israeli military, and the most notable one is published by Daniels and colleagues, and was published in JAMA from the Big Ten Athletic League. Now, Nick is at the University of Michigan. They're in the Big Ten League. That's where I went to graduate school. And let me tell you what, they evaluated every athlete. They had 30% of the students in 2020 got COVID-19, so because they checked everybody. And they searched thousands of athletes to see if they developed myocarditis. And we're talking EKGs, blood testing for troponin, escalating imaging up to cardiac MRI. Out of thousands of possibilities of people who got sick with COVID, they came up with about 36 putative cases where there was some abnormality by enzymes, troponin, or by imaging. And you know what? Not a single hospitalization or death.
So this is the paper that McCullough is talking about here. Now, when he says they searched thousands of athletes, it was actually 1,597. Not a number that most people would refer to as thousands, unless they were trying to mislead. And what this means is that the 37 cases of myocarditis that were diagnosed represents 2.3% of athletes who tested positive for COVID, which would equate to 23,000 cases of myocarditis per million cases of COVID. Not the nothing burger that McCullough is trying to imply. It is also worth mentioning that a lot of these cases were subclinical, so they were only picked up because they were looked for. The number of athletes that actually had cardiac symptoms was only 5, which equates to 3.1 myocarditis cases per 1,000 positive COVID tests, which is still much higher than the rate following vaccination. Now, McCullough also states that none of the athletes were hospitalised or died. He can't possibly know this because the study was based on the answers to a questionnaire sent to participating universities, and they didn't ask about hospitalisation or death.
But what happened was a false narrative came out of the hospitalized literature where people sick enough to be hospitalized with COVID were having elevations in cardiac troponin in the ICU, as would patients with pneumococcal or Haemophilus or other forms of pneumonia or ICU illness. None of those hospitalized cases were ever adjudicated to actually have myocarditis, but it was the elevation of troponin. So what came out of this was a false talking point that was carried forward by the American College of Cardiology and the government agencies that said that COVID itself causes more myocarditis than the vaccines. And nothing could be further from the truth.
Well, that sounds convincing. Of course, it is just more total bollocks. A large number of studies have been done looking at the incidence of myocarditis following COVID and the incidence following vaccination. In fact, so many studies have been done, researchers have even done a meta-analysis. And this is what they found. If anyone is not familiar with meta-analyses, this figure is what is known as a forest plot. And it shows the results of each study analysed in blue, as well as the overall results when the studies are combined in red. If a result is to the right of the vertical line and the error bar doesn't cross the line, it means there is an association between myocarditis and the intervention. So if we look first at COVID, we can see that all studies show that there was an association between COVID and myocarditis. And the combined effect has a risk ratio of 14.82, which means you are 14.82 times more likely to get myocarditis if you get COVID than if you don't. And these were all studies on unvaccinated people. And the reason I know that is because I went back to the original studies and checked the dates that they covered. There is, of course, also an increase in risk after vaccination, which is well known, but the risk is much lower at 1.95. This means that there is a 7 times greater chance of getting myocarditis after COVID infection than after COVID vaccination. And it's not just the incidence of myocarditis that is greater after COVID. The prognosis if you get myocarditis after COVID is also worse than if you get it after vaccination. And we know this because it was investigated in this study here. And what they did in this study is they compared the outcomes of 3 cohorts of myocarditis patients aged 12 and over who were admitted to hospital. The 3 cohorts were people who got myocarditis within 28 days of a positive test for COVID, people who got myocarditis within 28 days of a COVID vaccine, and people who got myocarditis who didn't fit the other 2 categories. And in each case, they looked at 90 days follow-up from admission to hospital. This is what they found. Compared with conventional myocarditis, people who got myocarditis after a positive COVID test were more likely to suffer heart failure and more likely to die, with a relative risk of 1.48 for heart failure and 2.35 for death, although the confidence interval for heart failure includes 1, so that's not statistically significant. In contrast, people who got myocarditis after vaccination had a significantly reduced chance of heart failure or death. The relative risk for heart failure was 0.56 and the relative risk for death was 0.48. Now, it's important to note that this study was looking at the incidence of heart failure and death in the 90 days after hospital admission for myocarditis, but they didn't establish causality. So some of the events will be incidental because there is a baseline rate of heart failure and death across the whole population. But essentially, the study is showing that the rare cases of myocarditis that occur following vaccination have a better clinical outcome than cases following COVID or cases from other causes.
I have this report that's so interesting by Nakahara and colleagues regarding abnormalities in cardiac positron emission tomography. There are about 700 vaccinated, 300 unvaccinated, getting PET scans for other reasons, but they had very good cardiac imaging. And it was striking where virtually every vaccinated person the myocardium shifted from preferring free fatty acids to preferring glucose as a metabolic substrate, and it's tagged with 18-fluorodeoxyglucose. Now, when I order a cardiac PET in practice, I'm looking for an ischemic zone of myocardium. Here, the entire left ventricle actually took on, in almost every vaccinated person, the appearance of an ischemic left ventricle, whereas those unvaccinated had normal PET scans, no FDG uptake. And I looked at the paper carefully, and the only thing that makes sense to me, Dr. Campbell, is that there may be microthrombi, or just RBC hemagglutination, which is well described with the spike protein, and in the small capillaries of the heart to create these metabolic changes. So, and this was seen even out to 6 months after the vaccine. So we have to posit that it may not be all myocarditis, it may be a form of a metabolic cardiomyopathy or other abnormalities, but it appears to be common, and we may just be seeing the tip of the iceberg.
Again, McCullough is misrepresenting a study and being loose with the truth. To his credit, he does mention that they had PET scan for other reasons, but he doesn't mention what the other reasons were. Now, the main reason was because they had cancer, although there were some people who had them for other reasons as well. But it wasn't a healthy population. And what he doesn't mention at all is that in order to get an accurate cardiac result, patients need to follow a high-fat, low-carb diet the day before the imaging. If this is not done, the results aren't accurate because the patients won't have switched off their use of glucose. And it was not done in this case because the patients weren't being prepared for cardiac imaging. They just use images taken for other reasons. Now, when he says virtually everyone who was vaccinated had a scan that looked like an ischemic heart, that is just a bald-faced lie, just as is the claim that everyone who was unvaccinated had a normal result. There was a shift to more abnormal FDG uptake results in the vaccinated, but it wasn't everyone, and abnormal results were also seen in the unvaccinated. And importantly, we don't know how many abnormal results were just the result of the patients not undergoing the correct preparation for cardiac imaging. Now, the authors also mentioned that owing to the limitations of their retrospective study, a prospective study should be done to properly investigate this. Unknown to them, a prospective study had been done prior to their study being published, and this is it here. So what they did in this study is they followed up 54 patients 2 months after COVID vaccination and performed, amongst other things, an FDG PET scan. 17 of the patients they chose were symptomatic with myocarditis after their vaccination. 17 were symptomatic but didn't have myocarditis after vaccination, and 20 were asymptomatic after vaccination. Amongst those who didn't have myocarditis, there was no FDG uptake and no blood biomarker abnormalities either. Amongst the 17 who had been diagnosed with acute myocarditis following vaccination, 2 of them had focal FDG uptake at 2 months. The rest didn't. And there was no adverse cardiac events beyond myocarditis in any participants. So the retrospective study looking at images taken for another reason amongst patients who were ill and hadn't prepared properly for cardiac imaging was interesting, but a prospective study didn't show any abnormal FDG PET images in any vaccinated who hadn't been diagnosed with myocarditis previously, and even most of those had normal images at 2 months post-vaccine.
About 70% of the world's population have had at least one COVID vaccine. And looking back, the incredulity is just huge that this could be done without proper cardiac studies. a lot of people in my comments are really concerned that there's an epidemic of heart failure and other heart pathologies, but probably particularly heart failure, or increased cardiac arrests, or increased coronary arterial atherosclerosis coming. Are these fears in any way justified?
I think they are, but COVID, the respiratory illness, and the vaccines need to be factored in. And important citations. One is by Xi and colleagues from the U.S. Veterans Administration, clearly demonstrating after COVID, respiratory illness, there's about a 6-week period where older individuals are at increased risk for myocardial infarction, stroke, and cardiovascular death. So it's a post-viral risk, probably related to, atherosclerotic inflammation. By the way, very similar pattern after influenza. Same type of pattern. So it's true.
Well, it's not surprising that Campbell sees a lot of worried commenters, given that he is continually lying to them about vaccine risks. Thankfully, most people aren't exposed to his nonsense and are continuing to lead happy lives. But it was nice to see McCullough admit that COVID does increase your cardiovascular risk, although increased risks are seen for at least 12 months and not just 6 weeks, like he says. And the increased risks are seen in both young and old people, although the absolute risks will be higher in old people because they have a higher baseline risk.
Dr. McCullough, would it be inappropriate to speculate the proportion of the excess deaths that we're currently suffering from at the moment are attributable to this, or is that a completely unreasonable question?
We need a lot more studies. I think what's really needed, which would be very helpful for temporal association, is I think all countries should merge the vaccine administration data and the death data. Yeah. And, a lot of countries have this. It's simply merging, and if we saw spikes temporally associated with when people took the vaccines, we could zero in on these deaths. Dr. Campbell, in the United States, our CDC VAERS system indicates that we've had about 18,000 Americans who have died, and people report them to VAERS. I've made these reports as a doctor. I made a VAERS report today, so I'm very familiar on how to do it. 18,000 where we think the vaccine caused the death. Okay, so this is highly selected for, we think causality is there. Do you know of those 18,000 plus, 1150 occurred on the same day they took the shot, sometime right in the vaccine center. And then another 1,200 is the next day afterwards. So even if we draw a very close time stamp here, we're looking at 30 days here, I can tell you if this was a drug trial, and I was chairing the Data Safety Monitoring Board, which I've done about 24 times in my career, we would say, listen, anything within 30 days, any event is attributed to the experimental product, period. It's just a regulatory standard.
I'll let John answer that one.
Because what we have to remember, of course, is the people that were vaccinated first were the elderly and those most at risk that were vaccinated first. And of course, it's just part of life that these people often die frequently. The probability of surviving the year goes down quite substantially. So for this proportion of vulnerable people and elderly people to die after they've received a vaccine is not surprising. They would have died whether they'd received the vaccine or not. How do I know this? Well, these are all reported. A review of available clinical information is carried out by physicians from the CDC and the FDA. They get all the information. They look at death certificates. They look at autopsy reports. Now, we don't have autopsies in the United Kingdom, in England, Scotland, Wales, Ireland. We have post-mortems, after death. It's the same thing. You basically get the body and you examine it to work out the cause of death and bits and bobs about it. They take into account medical records. And by the way, post-mortem information, autopsy report, is the most accurate diagnosis you can possibly get because you're actually looking at the diseased organ. Medical records, and the bottom line is all of these revealed no link with vaccinations. So if you take an elderly group of people You take 41 million of them. It's not surprising with the normal cycle of life that 1,170 of them die within a relatively short period of time of any specific point in time that you are talking about. It just so happens that this point in time was when they were vaccinated. So this reflects the cycle of life. It does not reflect a problem with the vaccines.
So as John explained so well, people do die all the time. So you would expect a certain number of them to die following the vaccine. Rather strange that he didn't explain this to McCullough during the interview. But McCullough does make a good suggestion about comparing deaths with the vaccine rollout. It just so happens that Dr. Roger Schwelt of MedCram has actually done this analysis, and he covers it in this video here, which I'll provide a link to in the video's description. And by the way, he's also done a good one explaining the VAERS data, which I'll also link to. But spoiler alert, excess deaths don't correlate with vaccines, but they do correlate with COVID waves. Now, no doubt I'm going to get the usual, why don't you debate McCullough or have him on your channel? I couldn't even if I wanted to, as he has blocked me. No idea why. I've never interacted with him, and at the time he blocked me, I had never even mentioned him. So, in summary, just because someone is a highly cited cardiologist, it doesn't mean we should blindly accept their claims, like Campbell does. Myocarditis is a rare side effect of COVID vaccination, and it should be taken seriously. But lying about the incidence of myocarditis before the pandemic and after COVID and misrepresenting papers to make it seem worse is just blatant disinformation. If you'd like to look further into the data I've presented, I've provided links in the video's description. And please remember this video is about the science, but you shouldn't take it as medical advice. For that, you should speak to your medical practitioner. If you've got this far, thank you for listening. And if you've liked, shared, or commented on the video, double thank you, because that helps the algorithm and means that more people will see the video. And of course, thank you to everyone who has bought me a coffee or little Cindy here a treat. We really appreciate your support. We will be continuing to make videos about the science in the future. So if you'd like to join the cool kids and stay informed, please hit the subscribe button. Thank you.